Jokes aside, okay, maybe let's not put the jokes aside. But anyways, I have been putting this topic off for the longest, and I thought today, maybe let's do this. Grab a piece of paper, let's go. Hello and welcome to MK's Medical Review series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we'll look at medical topics in depth. Today we're going to start a series of lectures, which is going to be pretty much in 3 parts. We're going to look at hypertensive disorders of pregnancy. In this episode, we're going to be looking at gestational hypertension and pre-eclampsia. In part 2 of these lectures, we're going to be looking at eclampsia. And in the last part, we'll look at chronic hypertension with or without superimposed preeclampsia. I hope at the end of these 3 videos you have a very good understanding of how to differentiate between gestational hypertension, preeclampsia, eclampsia, as well as chronic or pre-existing hypertension with or without superimposed preeclampsia. If you haven't yet subscribed to the channel, please subscribe to the channel, hit the bell notification icon to get notifications of such videos every time I post. Drop a like, drop a comment to Zambia and beyond, grab your piece of paper. Let's go. Here's a warm-up question. A 39-year-old G1 para0, I don't know why they didn't just say prime gravida, at 39 weeks gestation is sent to labor and delivery for her obstetrician's office because of a blood pressure reading of 150/100, obtained during a routine obstetrics visit. Her baseline blood pressure during the pregnancy was 100 to 120 systolic, 60 to 70 diastolic. On arrival to labor and delivery, the patient denies any headache, visual changes, nausea, vomiting, or abdominal pain. The heart rate strip is reactive and the tocodynometer indicates irregular uterine contractions. The patient's cervix is 3 centimeters dilated. Her repeat blood pressure is 160/90. Hematocrit is 34. Platelets is 160,000. The AST is 22, the ALT is 15, and urinalysis is negative for proteins. Which of the following is the most likely diagnosis? A. Preeclampsia. B. Chronic hypertension. C. Chronic hypertension with superimposed preeclampsia. D. Eclampsia. E. Pregnancy-induced hypertension, which is your gestational hypertension. You may pause the video at this moment, write down your answer, scream it at the screen, or talk to a friend if you watch the videos with a friend. Then I will give you the answer at the end of the lecture. So let's get into these hypertensive disorders. Remember that hypertension is by far the most common medical condition that's going to be encountered during pregnancy, and it's actually going to be complicating roughly about 10% of the pregnancies. There are predominantly 4 different categories that I want you to take note of. The first one is known as gestational hypertension. The second one is known as preeclampsia, eclampsia. The third one is known as chronic hypertension. That's pre-existing hypertension without superimposed preeclampsia. Then the fourth is preeclampsia superimposed on chronic hypertension. Those are the 4 categories that we're going to be looking at mainly in the next course of the 3 videos. Now, when you look at gestational hypertension, this is also referred to as a transient hypertension of pregnancy. So you can also refer to it as a non-proteinuric pregnancy-induced hypertension because you don't have any proteinuria. And remember that hypertension happening in the later half of pregnancy, greater than 20 weeks, you refer to this as gestational hypertension. Rule of thumb is gestational hypertension, preeclampsia, and eclampsia are going to be all occurring after 20 weeks. Preeclampsia and eclampsia can sometimes occur earlier, but if it does occur earlier, you should actually investigate this pregnancy for other major complications, or this could even be a molar pregnancy, for example. Then you may have chronic hypertension which pre-exists before the 20-week mark, as well as the chronic hypertension which may complicate and have a preeclampsia superimposed. Then when you talk about pregnancy-induced hypertension, what you're actually meaning is one of the 3 things, where you're talking about gestational hypertension or preeclampsia or eclampsia. And just to remind you a little bit about the mean arterial pressure, It's going to be equal to 2/3 diastolic pressure plus 1/3 of the systolic pressure. Remember that the mean arterial pressure is very important because this is going to be needed to perfuse many different organs, including the brain. The mean arterial pressure greatly influences the cerebral perfusion pressure because you have to factor that in. You also have to factor in the intracranial pressure. Now, what are some of the definitions that we have to actually look at? So remember that for us to say that this person has hypertension in pregnancy, they first need a sustained elevation of their BP of greater than 140 to 90 millimeters of mercury on 2 occasions more than 4 to 6 hours apart. Some literature gives you 4 hours, some literature gives you 6 hours. That's one definition that you can have. The second definition is that the diastolic pressure is greater than 110 millimeters of mercury on 1 occasion. The third is if you get a rise more than 30 millimeters in systolic over the booking blood pressure. The first time that the patient came there, if the systolic blood pressure has risen greater than 30 millimeters of mercury, then you say that they have pregnancy-induced hypertension. And if the diastolic rises greater than 15 millimeters of mercury as compared to the booking figure or the booking blood pressure. So if a woman has one of these things, then we can say that she has hypertension in pregnancy. Then we have to further now classify what type of hypertension in pregnancy does this woman have. So remember that when you're actually taking blood pressure in this patient, the blood pressure should be measured in the sitting position with an appropriately sized cuff. And there is some controversy of when to actually take the diastolic pressure. There are some people say that you should take it during phase 4 of the protocol for sound, when the sounds are muffling out as opposed to when they disappear. But standard practice is you should take the diastolic pressure when the sounds disappear. And remember that blood pressure is measured on the right arm with the patient lying on her side at 45 degrees to the horizontal. And in an outpatient setup, the sitting position is actually preferred. And in other cases, you're going to be occluding your brachial artery, and this should be kept at the level of the heart. Remember that in any normal pregnancy, the blood pressure is actually going to be falling during the first trimester. So this is because of the effects of progesterone, the peripheral dilatation or vasodilatation that is an effect of progesterone. Then it's going to reach a baseline in the second trimester, so roughly between 24 to 28 weeks. Then it will gradually rise until it reaches term. Then after you give birth, it's supposed to drop a bit, but it doesn't really reach the baseline that this patient was at before they got pregnant. And remember that a rise in blood pressure at booking, which is usually done roughly around 16 weeks for most women, is usually due to chronic hypertension. So if this woman comes at 16 weeks or 14 weeks or whatever weeks, if it's below 20 weeks and her blood pressure is elevated, then this is most likely she had it before she even got pregnant. So this is a chronic hypertension, and it's also referred to as essential hypertension. It's only in rare cases where you may actually find a cause, and maybe a renal disease or maybe even a pheochromocytoma, but those are rare isolated cases. So remember that hypertension before pregnancy or during the early stages of pregnancy is going to be associated with a twice increased risk of gestational diabetes mellitus. They go hand in hand. And gestational hypertension and preeclampsia only very rarely occur before 20 weeks. And like I said, these are often associated with trophoblastic diseases. Those are your molar pregnancies. So what's the comparison between the three conditions before we dive into looking at gestational hypertension and preeclampsia? Remember that preeclampsia is mostly in the young, gestational hypertension is in the young, essential hypertension is usually in the elderly. Then when it comes to parity, preeclampsia is very common in the prime gravidas. Gestational hypertension also can be found in the prime gravidas. Essential hypertension or chronic hypertension is common in multiparous women. In preeclampsia, there may be a past history of preeclampsia in the previous pregnancy, even with gestational hypertension. And remember that with essential hypertension, this person will already have a pre-pregnancy hypertension history before they got pregnant. Then in the family history, preeclampsia may be present in the family. Gestational hypertension usually is not related to family history. Essential hypertension is often going to be present. You may have a family history. Then usually preeclampsia is after 20 weeks. Gestational hypertension is usually in the third trimester. Then essential hypertension is before 20 weeks. Then the follow-up BP following delivery, usually with preeclampsia and gestational hypertension, they subside completely. Then essential hypertension persists beyond the puerperium. It persists after even 3 months. Then when you look at proteinuria, you may have proteinuria in preeclampsia and eclampsia. You may have gestation, you do not have the proteinuria in gestational hypertension. You may sometimes have it in essential hypertension, but it's usually absent. You may get some eye changes, especially in essential hypertension, the silver wiring of the arterioles, as well as hypertensive retinopathy. I did a very nice video on that. If you haven't checked that out, please check that out in the internal medicine playlist. Then you may have in gestational hypertension, you do not have any eye changes, but in preeclampsia, you may have some extreme cases where you actually have retinal edema, you may have constriction of the arterioles, you may have nicking of the veins. There was one such case where a woman actually went blind because of preeclampsia, but it was more of a reversible type of blindness. So once that was addressed, she regained her sight. Then when it comes to the laboratories and the blood values, there is some hemoconcentration, thrombocytopenia. Sometimes the serum uric acid is greater than 5 milligrams per deciliter. There may be raised liver enzymes in preeclampsia. Then with gestational hypertension, this is obviously absent, and essential hypertension is not as significant. So keep this in mind, because this is a very good preliminary to start the hypertensive disorders of pregnancy. And make sure you do not skip any video and watch them in this particular order, because information is going to build on the previous videos. So let's go into details about gestational hypertension. Remember that here there's going to be a sustained elevation of the blood pressure, greater than 140/90 after 20 weeks without any proteinuria, so no features of preeclampsia. And this should occur 2 occasions 4 to 6 hours apart. And you can also define it as the BP doesn't really come back to normal after 6 weeks of delivery. So in the puerperium, after the puerperium, the BP doesn't return back to normal. Then you say that this person has gestational hypertension. So there are some criteria that have to be ticked. Number 1, the blood pressure should be greater than 140/90. Number 2, the pregnancy itself should be greater than 20 weeks. Number 3, there shouldn't be any features of preeclampsia, no seizures. In eclampsia, there shouldn't be any proteinuria. Number 4, the rise in the BP should be at least 2 or more occasions, 4 to 6 hours apart. Then number 5, the BP does not return back to, or rather the BP returns back to normal. Sorry if I say the BP does not return back to normal. Apologies on that. The BP actually returns back to normal after the puerperium. So remember that with gestational hypertension, it's not going to be associated with proteinuria. And women actually initially present with apparent gestational hypertension in about a third of the cases. They actually even develop preeclampsia. So it's actually very careful. You should be observing this woman carefully, because they may actually progress to preeclampsia. The pathophysiology is actually not so known, but in the absence of features of preeclampsia, the maternal and the fetal outcome actually usually are normal. Paternal, or rather prenatal and maternal complications are generally low, but gestational hypertension can actually be the precursor to someone actually developing chronic hypertension later on in life. So although if the maternal diastolic pressure is less than 1/110, then most of the complications are averted. Immediately that diastolic pressure begins to rise and is greater than 1/110, there is an increased risk of placenta abruption, there is an increased risk of fetal growth restriction, there is an increased risk of superimposed preeclampsia actually happening, and even the morbidity increases, the mortality increases. So what are some of the clinical features? Remember here that no symptoms of preeclampsia, no headaches, no epigastric pains, no visual blurring. And the physical findings are unremarkable for pregnancy. The only thing that is going to be hinting you is that this person will be greater than 20 weeks and they will have a high BP. That may just be the only thing. What's the diagnosis? So on the history, there are no symptoms of preeclampsia. When you do the labs, there is no proteinuria. And what's our diagnostic triad? So like I said, a BP that's greater than 140/90 on 2 occasions, at least 4 to 6 hours apart, no proteinuria, and the pregnancy is greater than 20 weeks, then this fits the bracket of gestational hypertension. How do we manage these patients with gestational hypertension? So generally, it's going to be a conservative outpatient management if it's appropriate. So antenatal visits. So they can visit every 2 weeks until they are at 28 weeks gestation. Then after that, they visit the hospital weekly. Then on each visit, you should actually do a urinalysis, send blood for liver function tests, creatinine, a full blood count to actually gauge and see if there's any progression of the disease. So close observation is actually quite important because we do not want these patients to progress to preeclampsia. We advise them to get some bed rest and we treat the hypertension. So if the diastolic blood pressure is greater than 110, we give them hydralazine. Generally, the drug of choice, according to the literature, is actually labetalol, but hydralazine is what we usually have readily available in the hospital. So we give them 5 to 10 milligrams IV every 15 to 60 minutes until their BP is less than 160/110. So the maximum dosage you can actually give is 30 milligrams if you're giving it IV. So your maintenance dose is 10 milligrams per hour. Or you may give them labetalol 10 to 20 milligrams IV every 10 minutes until their BP is less than 160/110. And of course, the maximum that you can give is 300 milligrams IV, and the maintenance dose is 40 milligrams per hour. Then, if their BP is persistently greater than 160/110, despite you giving them hydralazine, you can add an nifedipine that you can actually give sublingual, 10 milligrams, until their BP is controlled. Then once their BP is less than 110, we generally want to put them on methyldopa and or nifedipine. So methyldopa 250 to 500 milligrams 3 times a day or 4 times a day. Nifedipine 10 to 20 milligrams twice a day orally. Of course, you want to keep the diastolic roughly at around 90 millimeters of mercury. Then after they give birth, we actually put them on atenolol if their BP is still greater than 160/110. So there is no indication for actually delivering the child prior to term, 37 weeks or at least 34 weeks. If things are so bad, at least try to aim to get the pregnancy to 34 weeks. So if the blood pressure is well controlled, there is no indication for delivery. So after this, after they reach term, then they can be delivered. So delivery at 38 weeks gestation if they are stable and they are asymptomatic. So induction of labor if there's no contraindication to vaginal delivery, or C-section if there is a contraindication to vaginal delivery. And of course, when you perform the active management of the third stage of labor, remember that ergometrin is not going to be used because it's contraindicated in patients with hypertensive disorders. So we want to use oxytocin. What's our differential diagnosis? Preeclampsia is our differential diagnosis. So we'll now look at preeclampsia because we had focused on the gestational hypertension. Now we're now moving a step further and looking at preeclampsia. Remember that here you're going to be having a sustained BP, the same readings, greater than 140/90 on at least 2 separate occasions, 4 to 6 hours apart. So this is going to be in the presence of at least 300 milligrams of protein in 24-hour urine collection, arising after 20 weeks gestation and in the absence of pre-existing hypertension. So around 300 milligrams of proteins per 24 hours, maybe that's roughly about, I could say 2 plus, greater than 2 plus. Because remember, trace is 0.1 grams per liter, 1 plus is 0.3 grams per liter, 2 plus is 1 gram per liter, 3 plus is 3 grams per liter, 4 plus is 10 grams per liter. So I want to keep this as practical as possible. So our diagnostic criteria, you're going to be having a high BP, number 1. You're going to be in a patient that's greater than 20 weeks. So it could either be 140/90 on 2 or more occasions apart, or rather 4 to 6 hours apart. Then, or it could be a previous blood pressure is not known and there's a rise in their blood pressure, their systolic by 30, diastolic by 15 from the booking blood pressure. Remember those 4 definitions that I gave you. And in the presence of proteinuria over 24 hours. Now, what you really need to note that now actually we are using actually much more specific tests for this. You don't actually necessarily have to collect the urine over 24 hours. You can do actually spot tests. What is referred to as the urine protein creatinine ratio, or in short PCR, and the albumin creatinine ratio, the urine albumin creatinine ratio, the ACR. So the normal PCR is not more than 200 milligrams per gram. So we can use these ratios and they can actually tell us if someone has significant proteinuria or they don't. And remember that proteinuria is the presence of total proteins in 24 hours that are more than 300 milligrams, greater than 2 plus, on at least 2 random clean cat urine samples tested 4 or more hours apart in the absence of a urinary tract infection. So what do I mean? A woman comes in, you test the urine there, you find that it's greater than 2 plus proteins in the urine, then maybe you test it after a few hours. Again, on a clean cat sample, you find out that it's greater than 2 plus proteinuria, then you can say that this person has significant proteinuria. Or indeed, if you have the facility to do the PCR or ACR, you can do that. And remember that with preeclampsia, just like with gestational hypertension, it does resolve after 6 weeks. So after the puerperium or within the puerperium period. So there may be some edema that may be present in a normal pregnancy. But remember that edema is no longer part of the diagnostic criteria when it comes to the diagnosis of preeclampsia. It used to be, but it's no longer part of the diagnostic criteria. And remember that when preeclampsia actually appears before 20 weeks, we should actually consider our trophoblastic diseases, your hydatidiform mose, as well as acute polyhydramnios. Another change that was actually made is that we now classify preeclampsia as just mild and severe. Way back, it used to be mild, moderate, and severe. So take note of these changes when you're reading the newer literature. So how do we distinguish between the two? So with mild preeclampsia, there'll be a sustained BP, systolic 140 to 159, diastolic 90 to 109, at least in the pregnancy that's after 20 weeks gestation without any pre-existing hypertension and associated with proteinuria. So that's 1 to 2 plus proteinuria. Then our diagnostic triad is going to be our pregnancy greater than 30 weeks, sustained high blood pressure, and proteinuria. So that's mild preeclampsia. Then severe preeclampsia, the BP is greater than 160 over 1110 after 20 weeks of gestation without pre-existing hypertension and associated with proteinuria. Here the proteinuria is a bit higher, about 3 to 4 plus. So our first triad, you could have a pregnancy greater than 20 weeks, a sustained BP, and proteinuria 3 to 4 plus, or they could have symptoms. What are these symptoms? I've listed them down here. So they could have headache, severe persistent epigastric pain, visual changes, retinal hemorrhages, exudates, or papilloedema. Or they may have disseminated intravascular coagulation and increased liver enzymes, platelet count less than 100,000, pulmonary edema features, HELP syndrome, which I will talk about, intrauterine growth restriction, pulmonary edema, and even oliguria, which is a urine output less than 400 milligrams of 400 mils in 24 hours. So if they have symptoms of target end organ damage, then we consider them as severe preeclampsia. If they just have the BP and the proteinuria and the pregnancy is about 20 weeks, above 20 weeks, we just consider that as mild. If they have end organ damage or the BP is very high, we consider that as severe. Notice how edema is not being used, because edema is usually just part of a normal pregnancy. It's just that it will be out of proportion when it comes to preeclampsia, but we no longer use it as a diagnostic criteria. So we'll begin with mild preeclampsia. So here they sustain BP 140 to 159, systolic 90 to 109, diastolic on 2 occasions more than 4 to 6 hours apart after 20 weeks gestation in the absence of pre-existing hypertension with proteinuria. Your definition must always have these things. Then that's about 300 milligrams in 24 hours. So what are some of the risk factors in primiparous women? So it's 8 times more likely in primiparous women, because it's thought that the normal fetal maternal transfusion occurs during pregnancy, and this actually particularly exposes the mother to products of the fetus and the paternal genome, and then actually her immune system kind of quote unquote protects her in the subsequent pregnancies, which is what may lead to higher blood pressures in the subsequent pregnancies. Then in multiparous women with a history of preeclampsia in the previous pregnancy, like I said, in obstetrics and gynecology, if you've had a condition before, most likely you may have it again. So the age extremity, so 10 years or more since the last baby, having a child greater than the age of 40, then a family history of preeclampsia and hypertension, especially in first degree relatives, so a mother or a sister, a BMI greater than 35, kilograms per square, or actually kilograms per square meter, then that's obesity, multiple gestation, placenta abnormalities like hyperplacentosis, which is excessive exposure to chorionic villi. That could be in cases of molar pregnancies, high density for moles, twin pregnancies and diabetes, placenta ischemia, and some other medical conditions like diabetes mellitus, pre-existing vascular conditions, chronic hypertension, chronic renal disease, and thrombophilias, which may include antiphospholipid syndrome, protein C and S deficiency, as well as factor V Leiden. Now, what's the pathophysiology? I really want you to pay a close attention here, because this is going to be a similar discussion to what I actually discuss when I look at eclampsia, just at a much more severe degree. So the exact pathophysiology of preeclampsia is actually not really known. But what we know is that there is a problem with the placentation. So there is a placental dysfunction. Remember that this placental dysfunction is that's going to be leading to this syndrome where there is endothelial dysfunction that's associated with vasospasms of almost all the blood vessels, but particularly in the uterus, the kidneys, the placental bed, and the brain of the mother. So keep this in mind. I will explain this in a whole lot detail very shortly. So I want you to recall a few things. So the first concept that I want you to remember is the placenta is going to be formed from the trophoblastic cells, the syncytial trophoblastic cells and the cytotrophoblastic cells, which are supposed to be invading into the decidua, which is what the endometrium is called during pregnancy, and going towards the spiral arteries, which are found in the myometrium. Remember, these are the terminal branches of the uterine arteries. Now, these are getting closer to the spiral arteries because the spiral arteries are the ones that are going to be bringing in nutrients for the child and taking away waste materials. So for this actually to happen successfully, the trophoblastic cells, number one, have to invade into the decidua effectively. Number two, the spiral arteries actually have to undergo remodeling. So initially they were narrow, as you can see at the bottom of the screen, they're narrow. The endothelium there and the smooth muscle, the tunica media, they're narrow. But they're supposed to now enlarge and become more twisted. So they become large and they become tortuous. This allows a lot of blood to actually flow through the uterus. So there are two waves of invasion of these trophoblastic cells. The first wave actually happens at 10 to 12 weeks, where the endovascular trophoblasts actually invade up to the decidual segments. Then the second trimester is where you have the second wave of invasion, which is at 16 weeks to 18 weeks, where you have these trophoblastic cells invading up until the myometrial segment, the junction between the decidua and the myometrium. Then the problem happens with the second wave. So in preeclampsia, the problem is happening with the second wave of the trophoblastic migration, such that now there's a reduction in blood supply to the fetal placental units because the blood vessels are not going to be increasing in diameter, they're not going to become tortuous. So what does this mean? That these blood vessels, these spiral arteries, will now become resistance vessels. They'll be causing a lot of resistance and not so much blood is now reaching into the placenta. So this process actually replaces the endothelial lining and the muscular artery wall by a fibrinous substance, so fibrinoid formation, and then the spiral arterioles actually become distended, tortuous, and funnel-shaped. So this is actually happening normally. So this is meant to lower the resistance, to lower the pressure, and to have a high flow system such that blood is flowing to the placenta or the fetal maternal unit. So in preeclampsia, you have a problem in the two things: invasion of the trophoblastic cells, especially infiltration of the cytotrophoblastic cells towards the spiral arteries, so beyond the decidual myometrial junction. And the second thing is that there is a problem with remodeling of the spiral arteries. So this means that this placenta is not going to be getting a good oxygen supply. And this actually becomes more of an issue as the pregnancy advances because the demands of oxygen are going to increase. So they'll reach a point where there's going to be a shortage of oxygen supply to the placenta, and this is going to cause it now to release several factors. So these factors are what are going to mediate the inflammation. One of the mediators is thromboxane A2, which is a potent vasoconstrictor in platelets, and this is going to be entering into the maternal circulation. So this is going to be causing vasospasms and vasoconstrictions. And remember that the vasospasms are going to be resulting from an imbalance between the vasodilators that are normally there in the maternal circulation, which are your prostacyclins and your nitric oxide, and the vasoconstrictors. Now, I want you to remember three important ones: angiotensin 2, thromboxane A2, and endothelin 1. So these factors now are going to be leading to damage to the maternal endothelium. So these are going to be giving you the characteristic features of preeclampsia. So the damaged endothelial cells are now going to lose their ability to control the vascular tone, so it becomes even harder for the blood vessels to relax. So they remain tonically contracted. Or constricted. This actually contributes to the increase in blood pressure. Then the factors that are going to be released by the placenta also are going to be increasing the permeability of the maternal vasculature. So if it's happening in the kidneys, this is going to be causing the proteinuria, which is the hallmark of the disease. If this is happening in other tissues, this results in edema because more fluid is exiting. This is edema outside what is seen in pregnancy. There is also an increase in oxidative stress, which causes endothelial injury and also increases capillary permeability and further worsening the edema. Then, of course, the spasms in the afferent glomerular arterioles can actually cause anoxic changes in the endothelium of the glomerular tuft and the glomerular endotheliosis, which can increase the capillary permeability and the protein leakage, and this actually causes the proteinuria. And remember that tubular reabsorption is also going to be decreased, and the albumin is going to be constituting 50 to about 60% of the proteins that are lost, and then alpha globulin consists about 10 to 15% of the total proteins that are lost in the urine. Now, the blood vessels that are involved can actually be damaged in many different organs. It can be damaged in the CNS. This can lead to headaches, seizures, visual disturbances. It could be affecting the liver. It could be resulting in epigastric pain, elevated liver enzymes, and even fetal growth restriction if the fetus is not receiving enough oxygen. Then the damage of the endothelial cells, remember that the endothelium is normal, and this actually prevents clotting of blood. So damage actually predisposes it to the blood easily clotting. So here's just the schematic to explain everything that I've talked about. So normally there are vasodilating factors that are present, your prostacyclins, and as well as prostaglandins. These are meant to increase vasodilatation, decrease platelet aggregation, and this in essence increases the utero-placental blood flow. So remember, these are products of the cyclooxygenase pathway, which is coming from arachidonic acid together with thromboxane A2. Now, what happens in preeclampsia is that now you have failure of the infiltration of the trophoblastic cells. You have the second thing is failure of the remodeling of the spiral arteries, such that now there is some ischemia, and you get these factors being released from the fetal circulation entering into the maternal circulation, one of which is thromboxane A2. You have other things such as endothelin. Oxidative stress is also present and producing this lipid peroxides, the reactive oxygen species, and the superoxide radicals. You also have some cytokines like tumor necrosis factor alpha, interleukin 6, vascular endothelial derived growth factor, nitric oxide, vascular refractoriness to the pressure agents actually is going to increase. And you also have angiotensin 2, which is a major thing. So these are going to be causing an imbalance now between the factors that are meant to be causing vasodilatation and those that are meant to be causing vasoconstriction, such that there is going to be more vasoconstriction. This leads to hypertension, a decrease in organ perfusion. If you decrease the utero-placental perfusion, this leads to intrauterine growth restriction. If there's a decrease in perfusion to the kidneys, it causes oliguria. If there's a decrease in perfusion to the liver, it causes ischemia. And it can also result in HELLP syndrome. I'll talk about HELLP syndrome. If there's a decrease in perfusion to the brain, this leads to the seizures. Then, of course, with the endothelial dysfunction, the capillaries become leaky. This causes the edema and the proteinuria. Then the activation of the coagulation system, which can cause thrombocytopenia. And in essence, there is also going to be some hemoconcentration. I really hope that makes sense and you understood that pathophysiology very well. So what are some of these symptoms of pre-eclampsia? So generally the symptoms and clinical features, generally patients are going to be having excessive weight gain and fluid retention outside the normal weight gain and fluid retention in pregnancy. So with the mild symptoms, there's going to be just some slight swelling over the ankles, which usually persists. when they get up from the bed in the morning, and even some tightness of the ring finger. This is a very early manifestation of preeclampsia. Then edema may actually extend to the face, the abdomen, the vulva, and even the whole body. But remember, edema is not used as a diagnostic criteria. What are some of the alarming symptoms that may point us towards severe preeclampsia? Headache, which is usually in the occipital or the frontal region. Disturbed sleep. Diminished urine output, less than 400 ml in 24 hours. Epigastric pain, which is often associated with vomiting. And you may sometimes vomit coffee color type of vomitus, which is due to hemorrhagic gastritis or due to subcapsular hemorrhage in the liver. There may be some eye signs like blurring of the vision, scotomas, you may have dimness of the vision, sometimes even complete blindness. But remember that the vision usually is regained within 4 to 6 weeks of delivery. So these symptoms are often due to spasms of the retinal vessels. So you have some retinal infarction. Sometimes it can be due to vasogenic edema occurring in the occipital lobe. Then you may sometimes have retinal detachment. Remember that reattachment of the retina usually occurs when the edema subsides and the blood pressure normalizes after delivery. So the presence of any new onset of persistent headache, epigastric pain, visual changes, this now moves the diagnosis from it being mild preeclampsia to severe preeclampsia. Then what are some of these signs? You may have abnormal weight gain within a very short period of time. So generally rapid weight gain is more than 2.27 kg a month or more than 0.45 kg a week in the later months of the pregnancy. This is quite significant. Edema on the ankles that may spread to the body. You may have a rise in blood pressure, which is usually insidious but may be abrupt. The diastolic pressure usually rises first, then the systolic follows behind. You may have features of pulmonary edema because of the leakage of the capillaries and the low oncotic pressure because you're losing most of these proteins in the urine. Then you may perform an abdominal examination that may show you some evidence of chronic placental insufficiency such as a scanty liquor or even growth retardation of the fetus. Remember that the manifestations of preeclampsia usually appear in the following order. So the first thing you have is a rapid weight gain, then you have visible edema, then you have hypertension, then you have proteinuria. Then the last feature to occur in preeclampsia is proteinuria. Remember that the difference between preeclampsia and eclampsia is seizures. In preeclampsia, you do not have seizures. In eclampsia, you do have seizures. And what are some of the laboratory findings? There may be some evidence of hemoconcentration, which may be shown by elevated hemoglobin, hematocrit, and even BUN, blood urea nitrogenous wastes. Serum creatinine and serum uric acid may also be elevated. Uric acid greater than 4.5 milligrams per deciliter, take note of the units. Serum creatinine greater than 1 milligram per deciliter, also take note of the urine, or rather the units. Then urinalysis may show proteinuria 1 to 2 plus. There may be a few hyaline casts and even epithelial cells, or even sometimes a few red blood cells. When you perform an ophthalmoscopic examination in severe cases, there may be retinal edema, constriction of the arterioles, alterations of the normal ratio of vein artery diameter, which is from 3 to 2 to 3 to 1. There may sometimes be atriovenous nipping. There may sometimes be hemorrhage. On ultrasound, there may be features of intrauterine growth restriction. Remember again, if you have intrauterine growth restriction, features of DIC, elevated liver enzymes, this automatically moves the diagnosis from mild preeclampsia to severe preeclampsia. What's the management? The only definitive cure is delivery. So, and removal of all the fetal placental tissue. That's when we cure this. So the objectives are as follows. So we stabilize the hypertension and we prevent progression to severe preeclampsia. We prevent any complications. We prevent eclampsia and delivery of a healthy baby in optimal time and restoration of the health of the mother in the puerperium. Those are our pretty much management principles. So the delivery may actually be deferred in cases of mild preeclampsia to minimize any neonatal complications of prematurity. And the underlying thing is that management is largely dependent on the gestational age. So if you get a patient that's before 38 weeks, so as long as the mother and the fetus are stable, do not deliver them. And they have mild preeclampsia, just manage them and watch and wait and see if she progresses to severe preeclampsia or she doesn't. Admit the patient, bed rest, because once there is some bed rest, this actually increases the renal blood flow. This causes some diuresis. This increases the uterine blood flow. It also improves the perfusion to the placenta, and this also reduces the blood pressure. There are so many people that underestimate the power of a good nap. and actually bed rest. So a high protein diet, 100 grams, usual salt intake, so there's no need for salt restriction, and fluids shouldn't be restricted in the cases of mild pre-eclampsia. Antenatal care should be done weekly until the delivery. Then, of course, send blood for LFTs, creatinine, a full blood count regularly, do ultrasounds as well, and a urinalysis regularly. For the antihypertensive drugs, we give them methodopa, 250 to 500 TDS or 4 times a day, 3 times a day or 4 times a day, and nifedipine 10 to 20 milligrams twice a day. Remember, this may sometimes give patients headaches. And for the maintenance, for maintenance dose, and we want to aim to keep their diastolic pressure around 90 millimeters of mercury. In the postnatal period, you can give them atenolol, especially if their BP is greater than 160/110. We want to monitor their BP at least 4 times a day, fluid input and output charts, daily weigh the patients, evaluate them for symptoms of severe preeclampsia, that's the headaches, epigastric pains, visual disturbances, oliguria, the fetal well-being, and also the bloods should be done at least once a week. Your hematocrit, your platelet count, uric acid levels, creatinine, and liver function tests. So expectant management actually should be extended judiciously to at least 34 weeks. However, after 38 weeks, if the BP is stable, you can actually deliver them, and you can actually use diluted IV oxytocin to induce labor if there are no contraindications to a vaginal delivery, otherwise perform a C-section. Then if the cervix is ripe, surgical induction can actually be done by low rupture of the membranes. This is the method of choice, and then oxytocin infusion can be used. If the cervix is not ripe, use prostaglandin E2 gel, that's 500 micrograms, intracervical, or 1 to 2 milligrams in the posterior fornix. You can actually insert this to make the cervix actually ripe. When the cervix is ripe, then you can actually perform low rupture of the membranes. So in severe preeclampsia, the antihypertensive drugs actually should be used during induction. And active management of labor, third stage of labor, should use oxytocin as opposed to egometrin. So if the pregnancy is beyond 37 completed weeks, we deliver them without actually even delaying because they have already attained term. Then if symptoms of severe preeclampsia or eclampsia occur, we should deliver them. We should consider delivering them regardless of the gestational age. What are some of the complications? So mild preeclampsia can actually progress to severe preeclampsia. And what's our differential diagnosis? It's chronic hypertension. So now what about severe preeclampsia? So remember that here there is an elevated BP greater than 160/110. What I've been talking about in the past was about mild preeclampsia. Now we're talking about severe preeclampsia. This is occurring after 20 weeks gestation on 2 occasions 4 to 6 hours apart, and it resolves within the puerperium period after delivery. Then the proteinuria is quite significant, greater than 5 grams per day, or they have symptoms like severe headaches, visual disturbances, epigastric, right upper quadrant pain, vomiting, and even some liver tenderness. Risk factors are the same as mild preeclampsia, but in addition, you may have diseases of small vessels like SLE, long-standing overt diabetes, primiparous women, multiple gestation, hydatidiform moles, diabetes mellitus, age extremities, chronic hypertension, and chronic renal disease. The pathophysiology is similar to mild preeclampsia, but actually here involves more severe diffuse spasms and more intense capillary injury to where the ischemia demonstrates itself in an overt manner, and usually here there is some multiple organ systemic injury. Clinical features: patients may include or present with severe headaches, epigastric pain, visual disturbances, so scotomas or blurriness, and the epigastric or right upper quadrant pain, vomiting, liver tenderness. The labs may show evidence of hemoconcentration. They may show proteinuria, 5 grams per day. There may be evidence of DIC or even hepatocellular injury, which is characteristic of severe eclampsia, or severe preeclampsia rather. They may have abnormal liver function test and even low platelets. Now our diagnosis here, and remember, we make the diagnosis based on the patient having mild preeclampsia plus one of the following, where they have a very high BP, 160/110, the proteinuria on dipstick is 3 to 4 plus or greater than 5 grams per day if you collect it over 24 hours, or features of maternal jeopardy. That's symptoms of a headache, epigastric pain, visual changes, thrombocytopenia, that's a platelet count less than 100,000, elevated liver enzymes, pulmonary edema, oliguria, and even cyanosis. Remember that edema may or may not be seen. It's not used as a diagnostic criteria. Now, what's the management of severe preeclampsia? In essence, the management of severe preeclampsia is very similar to that of eclampsia. So we want to admit and involve a senior doctor in obstetrics, involve the anesthesiologist team, plus or minus internal medicine team. There should also be some experienced midwives here. Stabilize the patient. So if they need intubation or ventilation, intubate them. From my experience, I haven't seen anyone that has needed intubation and ventilation so far. Then we treat the hypertension. So generally, hydralazine 5 to 10 milligrams IV every 15 to 60 minutes until the BP is less than 160/110. Labetalol 10 to 20 milligrams IV or labetalol 10 to 20 milligrams IV every 10 minutes until BP is less than 160/110. If it remains persistently elevated, nifedipine 10 milligrams sublingual can be given. Once the BP is controlled, methyldopa 250 to 500 TDS or QID, and or nifedipine 10 to 20 milligrams BD, which they can take orally, and we keep the diastolic blood pressure around 90. Postpartum, if they still have a BP greater than 160/110, atenolol can be used. So aggressive prompt delivery is actually indicated for severe preeclampsia, regardless of the gestational age, if there is evidence of maternal jeopardy or fetal jeopardy. If the mother is in danger, deliver. If the fetus is in danger, deliver. If both are in danger, deliver. So we generally want to control the BPs first, which is what we've done in the previous slide. We want to prevent seizures from happening. How do we prevent seizures from happening? We give magnesium sulfate, intravenous magnesium sulfate. So there are two regimens that you can actually use. The Pre-Triad regimen, which is what we use in our setting, and the Zuspan regimen, which we don't use in our setting. So the Pre-Triad regimen, we give 4 grams IV over 3 to 5 minutes. And we follow this by 10 grams as a deep IM, 5 grams in each buttock. Then the maintenance dose is 5 grams IM 4 hourly. We alternate buttocks. Then in the intravenous regimen, you give 4 to 6 grams IV over 15 to 20 minutes. Then the maintenance dose is 1 to 2 grams per hour IV. Now, you have to check a few things here. So we only repeat the injections if the following things are present. If the knee-jerk response is present, if the urine output is greater than 30, if the respiratory rate is greater than 12. So those are the 3 things that you must check for you to continue giving the doses of magnesium, because magnesium sulfate has some toxicity. If there is toxicity of magnesium sulfate, we stop it. We can give calcium gluconate 1 gram over 10 minutes. If there is a decrease in the respiratory rate and the urine output less than 30 mils, then we should also stop the magnesium sulfate. The therapeutic levels of serum magnesium is 4 to 7 milliequivalents, and magnesium sulfate is continued 24 hours after the last seizure or delivery, whichever comes first. So for those that have recurrent fits, if they do fit, then we can give them 2 milligrams IV bolus over 5 minutes and in the above regimen. Then of course we monitor the vitals. So we want to attempt a vaginal delivery with IV oxytocin if the mother and the fetus become stable. So we induce or augment labor if they are greater than 35 weeks. If they are preterm, then we can give them steroids to mature the lungs. So dexamethasone 6 milligrams IM every 12 hours for 4 doses. This is the one that we use in our setting, but we can also use betamethasone. Then the delivery is after 24 hours after the second dose. If they are less than 35 weeks and the BP is stable with less than 160/110 in severe preeclampsia, we start them on steroids, then we can deliver within 24 hours of admission for eclampsia. Then induction of labor is done when you get a Bishop score greater than 7. Then if it's less than 7, this patient would benefit from a C-section delivery as opposed to a vaginal delivery. Then the second stage of labor actually can be assisted with a vacuum or forceps delivery, but there is a concern for increasing BPs when you do these things. Then send blood for liver function test, creatinine and a full blood count, restrict the fluid intake to 80 mils per hour, or according to the urine output, which generally should be 1 mil per kg per hour, get a BP profile, then treat the pulmonary edema with furosemide if they do have pulmonary edema. So conservative inpatient management is actually rarely attempted in the absence of maternal fetal jeopardy, but from my experience, There are some patients that came in with severe preeclampsia and they were very, very preterm. For example, the patient is at 26 weeks and you know that if you deliver this child will not survive. So we can sometimes consider to actually conservatively manage them in the hospital, and then if things fail, that's when we deliver them. That's from my past experience. So if the BP can actually be brought to less than 160/110, then actually we should actually try and at least push the pregnancy a bit further. So remember that this should be taking place in a hospital setting with an ICU, and they should be constantly be on magnesium sulfate, and they should be managed for toxicity, and you should give them steroids to mature the lungs. Remember that how does magnesium sulfate work before I actually leave this chapter on management? So remember that it's actually thought to trigger cerebral vasodilatation as one mechanism. So this actually reduces the ischemia that is generated by the cerebral vasospasms during an eclamptic event. So magnesium sulfate also is going to be competitively blocking the entry of calcium into the synaptic ends, and therefore it's going to be altering the neuromuscular transmission. So those are just some of the mechanisms of action of magnesium sulfate that you may be asked on your exams. So here's our schematic of management of preeclampsia. So we generally want to hospitalize them, rest, BP profile 4 times a day, get your labs, ophthalmoscopy, and fetal well-being assessment. Then after that, make sure that you start them on antihypertensives if their blood pressure is greater than 110. If you control it and they are preterm, we can discharge them and then see them in antenatal clinic. If they are term, they should stay in the hospital, and because these patients have a tendency to cross their estimated date of delivery, so we should deliver them. So we deliver them by either induction with our prostaglandin E2 gel, artificial rupture of membranes and oxytocin, or a C-section, depending on the indication that is there. So if the BP is persistently high, we try to control the BP till the pregnancy is roughly around 37 weeks or at least 34 weeks, then we deliver them. If it's persistently increasing BP to severe levels despite using antihypertensives, or if there's features of severe preeclampsia, or you may feel like this patient may progress to eclampsia, we counsel the couple, we transfer them to a tertiary center, ideally give them prophylactic magnesium sulfate, and we deliver them irrespective of the gestational age. Steroid therapy if the pregnancy is less than 34 weeks. What are some of the complications of severe preeclampsia? So during the pregnancy, it may progress to eclampsia. You may have accidental hemorrhage, cerebral hemorrhage, oliguria, anuria, dimness of the vision, and even blindness. Preterm labor, HELP syndrome, acute respiratory distress syndrome, liver hematomas and ruptures, placenta abruption. During labor, you may have eclampsia, postpartum hemorrhage, which may be related to coagulation failure. In the puerperium, you may have eclampsia, usually within 48 hours of delivery. You may have shock. This is puerperovasomotor collapse, what's associated with contraction, or rather reduced contraction of sodium and chloride due to a sudden fall in the corticosteroid levels. You may have sepsis, which is due to increased incidence of induction and even operative interference, and low vitality. And long-term complications include residual hypertension, recurrent preeclampsia, and chronic renal disease. Fetal complications include intrauterine growth restriction, which is due to chronic placental insufficiency, intrauterine fetal death, which is often due to the spasms of the uteral placental circulation leading to accidental hemorrhage or acute red infarction. You may have asphyxia as well as prematurity due to spontaneous preterm onset of labor or due to preterm induction. Then when you talk about HELP syndrome, which is one of the things that can actually complicate these hypertensive disorders of pregnancy, the HELP actually is an acronym. H for hemolysis, EL for elevated liver enzymes, that's AST and ALT, LP for low platelets. So this occurs in 5 to 10% of preeclamptic patients, and it's actually an indication of immediate delivery because these women have a high risk of progressing to eclampsia. They have a high risk of progressing into liver failure. So when you do your peripheral smear, you may see schistocytes or helminth cells, which is just fragmented red blood cells. You may see elevated transaminases, your AST and ALT greater than 70 international units per liter. You may get a raised serum bilirubin level greater than 1.2 milligrams per deciliter, a raised lactate dehydrogenase greater than 600 international units per liter, thrombocytopenia less than 100,000 platelets. Risk factors: remember that HELP syndrome is twice much more common in multigravida women as prime gravidas. then there is going to be some epigastric pain due to subcapsular involvement of the liver, nausea, vomiting, right upper quadrant tenderness. There may be acute renal failure and DIC, and this actually is an increased incidence of placenta abruption. So remember that there is also an increased incidence of hepatic hepatoma and hepatic rupture. This may actually lead to profuse intraperitoneal bleeding, and the patients can actually die. Our differential diagnosis includes thrombocytopenic purpura, hemolytic uremic syndrome, and hypertension, although frequently seen, is not always present. Now, what's our management? So we stabilize the coagulation, so we transfuse them with platelets if they're less than 50,000, as well as FFP. Then that's fresh frozen plasma. We assess the fetal well-being, and we consider the need for delivery. So prompt delivery at any gestational age is actually appropriate. It's generally considered that we deliver them and for moderate to severe cases, but we may actually have some conservative management for the mild cases. Then postpartum vigilance is actually required because they may progress to eclampsia, and the incidence of recurrence in subsequent pregnancies is about 20%. We can actually use maternal corticosteroids that may actually enhance the postpartum normalization of the liver enzyme and the platelet count. What are some of the complications of HELLP syndrome? You may have disseminated intravascular coagulation, DIC, abruption of the placenta, ascites, hepatic hepatoma, as well as hepatic rupture. Now, just as I close this lecture, I just want to talk about two things. The first thing is the role of antihypertensives in pregnancy. Remember, methodopa is safe for pregnancy. Labetalol or atenolol can be used as alternatives. Beta blockers are going to be associated with intrauterine growth restrictions, so they shouldn't be used for a very long time during the pregnancy. Never, and I repeat, never use angiotensin converting enzyme inhibitors. Never use angiotensin receptor blockers because they are contraindicated in pregnancy. They are associated with fetal hypocalvaria, renal failure, oligohydramnios, and death. Diuretics should not be initiated during pregnancy unless if the benefits outweigh the risks, because these are usually associated with fetal adverse effects such as plasma volume reduction, diminished placental perfusion, and electrolyte imbalances. However, they can be used in special occasions, for example, cardiac failure, pulmonary edema, massive edema, and when combined with diazoxide when blood pressure is associated with fluid retention. So furosemide 40 milligrams, which is Lasix, is given orally after breakfast for 5 days in a week. In acute conditions, IV is preferred. I've seen the IV formulation being commonly used. So the BP target range actually is to maintain the diastolic values between 90 to 100 millimeters of mercury. Then the last thing that I want to talk about is the use of corticosteroids. Remember that corticosteroids are not only going to be beneficial to the infant, but to the mother as well. So in the fetus, there's going to be an increase in pulmonary lung maturity. So this decreases the incidence of intraventricular hemorrhage, and it decreases the incidence of enterocolitis when the child is born. Then in the maternal effects, this increases the thrombocyte count. It also increases urine output. Now coming back to our warm-up question. A 39-year-old G1 para0 at 39 weeks gestation is sent to labor and delivery from her obstetrician's office because of a BP reading 150 over 100. So this is quite high. And she's at 39 weeks, okay, so she has some gestational hypertension. So her baseline blood pressure was 100 to 120, 60 to 70. On arrival to labor and delivery, the patient denies any headache, so no features of severe preeclampsia, no visual changes, nausea, vomiting, abdominal pains. The heart rate is reactive, and the torcodynamometer, I don't know if I've butchered that, I'm sorry, I'm tired, indicates irregular uterine contractions. So the patient's cervix is 3 centimeters dilated. The BP is 160 over 90, which is high. Hematocrit is 34%. Platelets 160, okay, normal. ALT 22, normal. AST 22 normal, ALT 15 normal, urinalysis is negative for protein. So this already rules out preeclampsia. We do not have enough information for chronic hypertension because this usually occurred, her baseline during the pregnancy was usually normal. Then eclampsia, there are no seizures and there is no proteinuria, so this only leaves pregnancy-induced hypertension, which is your gestational hypertension, as the answer. I really hope this sheds some light on gestational hypertension as well as preeclampsia. If it did, consider subscribing. Stay tuned for part 2 of these lectures To Zambia and beyond, my name is Dr. Moses Kazevu. Until next time, bye-bye.